Hello, hello, hello. Good, good afternoon, students. Good afternoon. Welcome to the session. Am I visible to all? Am I audible to all? Can all of you hear me? Can all of you see me? Find it, book it, make it. Yes. Welcome all of you. Can somebody just put some comment in the chat box so that the chat box is also working? And is the audio video all clear? Okay, so yes, it was from what all we have got the yes. Okay, everything is fine. Can somebody just put some comments in the chat box so that I also know that the chat box is working properly? Is it clear to all of you? Yes, okay, super. But I can't, okay, yes. So, yes, from the feedback, I'm sure all of you must have realized it was a tough paper. And my dear students, some students found session one difficult, some found the session two difficult. But most importantly, is that it is absolutely clear. This is for all the future students or all those who are giving the future. It is absolutely a concept-based exam. Only those who have hashtag crystal clear concept. Yes, Neeraj Raghav, good afternoon, good afternoon. Yes, okay. So I'm sure all of you must have realized, and those who are giving the December FMG examination, please be very clear. Do not run after shortcuts right away. You have to focus on the concepts, and only concepts are going to get you through. It is hashtag crystal clear concepts. So only when the concepts are crystal clear, because one liner ka zamana gaya hai, factual MCQs are very less, clinical, integrated, big liners, and of course video based was a new thing. But don't worry, video based were in fact easy, because if you know the image you could answer it. Okay, so overall yes, the paper was tough. Okay, and yes, but a few of the questions, obviously under a few of the questions which I'll tell you will be coming in the NEET PG also, but you also should be prepared. Basically IBQs, if you know very well the image based, you can do it. Okay, so don't worry about it. But the take home message for all the future exams is that concept should be absolutely clear, and please focus more on the concepts, then only you can do it. And all those who are preparing, just I'll take 10 seconds, 6 months FMG course, everything you're going to get: the conceptual theory lectures, rapid revision MCQ, beautiful notes, my personalized timetable guidance. Get in touch with me on phone and WhatsApp on this number. Download the OGGuru app, and 6 months package starting from now till your Jan exam, free extension for 10 days also till Jan 9th exam. You are going to get it only in 1769. So I want all of you, those who are preparing for the upcoming exams, do not even wait for the results and enroll in this as soon as possible. Okay, now obviously all of you, please spread, this is the recall from what all students have posted me the questions from all the different sources. So you will help me to complete some of the options, and you will help me to frame the questions properly if there would have been difference. Okay, so let us begin. Yes, and now I'm so happy. Yes or no, the Rotterdam latest criteria. Okay, this was a question, and many of you have got it correct. That what is the new criteria? I had told you that when we are using a high intensity probe, the question was ultrasonographic reading as per the new Rotterdam criteria. Yes or no? Was it the same question or slightly difference in the question? Okay, so what we look at is follicle number per ovary. FNPO is the new concept, follicle number. Yes, old criteria. The old criteria was 12 or more than 12 follicles, and in the new criteria, because we're using more, yes, absolutely correct, more than or 20. Okay, 20 or more than 10, even in one ovary is okay. So it is not per section. Okay, per section or slice. When I do a sonography and when I do a section or a slide, usme 20 nahi hai. 12 was the old, 12 in one ovary was the old. Were these the options? And yes, 20 or more than 20 in one ovary also absolutely correct. Very good. So please keep this in mind. The terminology to be used, FNPO. What does FNPO mean? Follicle number per ovary. Even in the latest OG booster course, which I've told you, and in the recent advance also I've told you after PCOS lecture only, that these are the FNPO. Okay, by chance if it's per section, okay, per section or slice, then it's only 10 follicles, but that becomes very difficult. So that can come in the future exams. Okay, so keep this in mind. 20 or more than 20 follicles in one ovary is enough. That is the only change. Rest all Rotterdam is as it is. Okay, now moving on. Now here I need your help, my dear students. Many of the students are saying that it was a lambda sign, many are showing it is a T sign. So now you will have to tell me, okay, what is the time, what is the embryologically timing of cleavage when which of the following is seen. So all of you know this is the lambda sign, which we see it in DCDA, dichorionic diamniotic. Is it clear to all of you? and the other is the T sign or the inverted T sign or inverted T sign. Now this is where, okay, a video was there, okay, fine, yeah, so video would be there. So this was a video based question, and yeah, okay, so see, here you can see the confusion. Okay, Neeraj Raghav is saying surely a lambda sign, and Vital Nursing is saying it to the T sign. Okay, so here you will have to make an identification. All of you know the main purpose, that here there is something invades. Okay, something here, it's a right angle relationship, here it's a right angle relationship between the membranes and the placenta, and here something invades, and the answer would definitely change depending on what it was. Okay, so now it becomes difficult, but many are saying T sign, many are saying lambda sign, so we'll give you the answer for both, and that is how the way probably the recall will happen. So if you know that when it is less than 72 hours, we are going to get DCDA. DCDA is less than 72 hours, and when it is the T sign or this is monochorionic diamniotic, MCDA, because you are seeing a dividing membrane obviously. So in MCDA only you see a dividing membrane, and that is between 4 to 8 days. Okay, so now you decide, my dear students. Actually even I'm this, because exactly every student has told me half of, बहुत लोगों ने lambda sign बोला है, बहुत लोगों ने T sign बोला है. Okay, I repeat, if DCDA है, lambda sign है, answer becomes less than 72 hours. If it is a T sign or an inverted T sign, then it is 4 to 8 days as the answer. Is it clear to all of you? Yes. So let us proceed further, so that we get, the purpose of this is just to learn also for the future examination. Okay. Now tell me this. This was a video based question, and I'm sure all of you would have got this correct for sure. This was a video based question, yes or no? Ye kya tha? Yes. Okay, sir, this was a very simple, I'm sure all of you must have got it. We are holding the baby by the lower limb and rotating up onto the maternal abdomen. This is the Burns Marshall maneuver. Burns Marshall. Okay, Burns Marshall is the answer to this, and I'm sure this was a video. Okay, but videos were easy because I never crystal clear videos. Okay, Morris's Melevit mein kya hoga? Again I have told you the mnemonic, MSV. In MS, do MS. So MSV mein malar flexion. So if you see the doctor's hand going inside, okay, in MSV it is malar flexion. Will not bore you with lot of theory. Will quickly go to the answers. Only malar flexion, but shoulder traction. Is this clear to all of you? So when you get malar flexion and shoulder traction, that would be MSV. That can come in the future examination. Okay. Yes. Okay. Yes. So back should always face the doctor. So imagine the baby to be hanging down, and yes, back to face. Remember that. Okay. Back should always be anterior. Back should always be anterior. And this is definitely Burns Marshall, BM. Okay. So this was their clear cut. इसमें कोई controversy नहीं है. Burns Marshall is this. Pinards is for the popliteal fossa. Again, remember that if you get any of the, again future के लिए, if you get, my dear student, that somebody is putting the finger in the baby का popliteal fossa. Okay. P for Pinard, P for popliteal fossa. Okay, so if your finger is in the popliteal fossa, if that kind of an image is there, then that will be your Pinard's maneuver for the arrested lower limbs. Okay, that is to deliver the lower limb. Okay, is it clear? Yes. Okay, moving on to the next MCQ. Yes, now this is again absolutely super. We have discussed this many times in our lecture. Then now please help me complete the question. Okay, there was definitely amenorrhea for 2-3 years. Kitna tha? 50-year-old, suddenly hot flushes, profuse sweating. So we know basically all of it, that it is a lady who is having menopause. Now I got two kind of questions. What is the cause of this? Pucha tha, like why do the hot flushes come in? Please tell me. Or what is the most confirmatory investigation, or what is the next investigation to be done? Okay, so please pay attention that the question was, and all of you know that I have told you our pituitary is the master and ovary is the servant. Yes or no? Remember this, clap OG in the chat box. So pituitary is the master and ovary is the servant. I'm so happy. So many messages we are getting that, sir, almost everything, even though it was a tough paper, at least OBGY ne bacha liya. Many OBGY MCQs we could answer thanks to your lectures. So whenever the ovarian function is gone, ovarian function is completely gone, less, and ovarian function stop, the master will shout the loudest. And what is coming from the master? FSH, isn't it? Yes. So what is the answer to this? Serum LH also rises, but serum FSH is the most important, and serum FSH is going to increase. Estrogen is going to decrease. Progesterone will also decrease, of course, but the main thing what we do is we don't check the estrogen levels. They take time to go down. We will check the FSH levels. And anybody in the chat box, can you comment? Yes, FSH more than than 40, this is asked in the NEET PGPYQ, when the FSH is more than 40, that is confirmatory that the lady has reached menopause. Is this understood? Any changes were there in this question? Please let me know. Or the question was exactly like this. क्वेश्चन ऐसा ही था. Yes, confirm diagnostic perfect. DPFC2 correct. Okay, so sweating, hot flushes, and increase in FSH is the answer. If they tell you why does the hot flushes happen or with what do they coincide, so hot flushes happens because of decrease in estrogen, but they correlated with the LH secretion because LH pulsatile keeps on increasing. Okay, yes, moving on to the next question. Okay, yes, now this is very important MCQ. Okay, now just tell me again, here the slight confusion, but a gravida 2 para 1 living one, there is a RH negative lady, the husband is RH positive, and she is not received anti-D. Okay, previously the anti-D is not received. Okay, so anti-D not taken, or she is not sure if she has not taken the anti-D or not, anti-D not taken. Okay, तो इसमें आप लोग क्या करने वाले हो? Okay, yes, please understand this. The purpose of whole this is to find out whether the mother is immunized or not, or whether the mother is sensitized or not. Directly you do not give anti-D at 28 weeks. First you will do something and check. Okay, administer only after the next delivery regardless of the baby RH status? No. First, what am I supposed to know? Yes sir, ICT, indirect Coombs test. So whenever the lady is pregnant, during the pregnancy, very good all of you, we do the ICT. Why? Because ICT tells me whether the mother is sensitized or not. Only if the ICT is negative, because if the ICT is positive, then there is no role of anti-D. Is it crystal clear to all of you? If the anti-D is positive, then there is no role for giving anti-D injection. Only if the ICT is negative, then I will give anti-D. And what is the latest guidelines? Yes sir, then even during pregnancy, what is this called as? RAADP. I've discussed in my detailed lecture. Routine एंटीनेटल एंटी-डी प्रोफाइलैक्सिस. याद रखना है क्या है ये? RAADP, रूटीन एंटीनेटल. ओके, प्लीज कीप दिस इन माइंड. रूटीन antenatal anti-D prophylaxis. Okay, this is given at 28 weeks of gestation to the pregnant lady, and after delivery we do the baby's blood group and then find out. Okay, so performing the ICT to assess the maternal sensitization. Very good question, absolutely like a concept based MCQ that this was asked. A good question. She is not sure whether anti-D was given or not. What do we do right now? We do not give anti-D directly. First have to check the ICT and find out, because if the ICT is positive, there is no role of giving anti-D. Is it clear to all of you? Yes. What the fourth option may be something else. We have not got the fourth option. If anybody knows it, please comment, then we can also add it, but otherwise that does not matter, whatever will be the fourth option. And this was a pregnant lady, right? Somebody told me that sir, the patient had come in the before preconception. So was this a pregnant lady only? Pregnant lady question aaya tha, yeah, it had come in the interval period. It had come in the interval period, like in between two pregnancies. Okay, is it clear to all of you? Yes. Now moving on again, this is very important. All of you please pay attention. All of you please pay attention. Yes, this was something which uh, yeah, okay, so 35-40-year-old, exactly please tell me the time frame. Exactly please tell me the time frame kitna tha. What was the time frame of this lady? What was the time frame of this patient? And patients with post-coital bleeding, yes or no? Multiple episodes of post-coital bleeding aisa diya tha. And fourth option, okay, yes, okay, multiple episodes of post-coital bleeding, HCG negative. What is the most likely diagnosis? And everybody has told me, okay sir, cervical cancer was not in the option. Yes or no? Cervical cancer was not in the option. That was told to me by many students. Yes. And over here, my dear students, obviously PCOS wrong kachra. PCOS does not give post intermenstrual bleeding. See, please understand, what is important is that yes, whenever it is a what do you call it? Whenever it is a patient who has a post-coital bleeding, what all I have to think? Sir, anything which is coming out of the cervix. So cervical polyp, okay, cervical polyp, if it is there, then yes, cervical polyp, cervical erosion or ectropion is the answer. Endometrial hyperplasia will not give rise to post-coital, gives to post-menopausal bleeding or irregular bleeding. And submucosal fibroid is inside, so it will not cause post-coital. Okay, post-coital bleeding may cervical cancer, cervical polyp, all these are the options. Is this understood to all of you? And this, my dear student, is a very important image, because I thought it can come. So I'm just showing you, this is a cervical erosion, very angry looking, red in color. Okay, so this is the normal sign. This whole thing which you are seeing, okay, this whole thing which you are seeing, so it's a very vascular thing, and if the penis touches over there, they can present with post-coital bleeding, persistent white discharge. Thank you, Shubham Chal. Same. Thank you, thank you. Yes, yes, yes. Yes, it can cause bleeding. Yes. Submural, again, beta, submural fibroid. Got submural kya hoga, beta? Yes, there's nothing like submural. No, intramural fibroid will not cause postcoital bleeding. Okay, so this is the IBQ. Now this becomes a virgin IBQ. Okay, we have shown it in our actual. Like, this becomes a virgin IBQ for the future exams. Okay, for the future exams, this becomes very, very important. Is this understood to all of you? Moving on, moving on. Again, yes, a very, very good question. What was, now again tell me, was it bicornuate पूछा था या डाइडल्फस पूछा था, क्या पूछा था? What is the embryology? So it's integrated between anatomy, embryology and OBGYN. What is it? Yes, yes. Now tell me, failure of resorption of the midline results in septate uterus. So next year this question can come. Okay, septate uterus or septum is responsible for failure of resorption. First question, they mentioned both follicles and volume. Okay, yeah, so beta, ovarian volume is the same, ovarian volume criteria same, 10 ml or 10 cc is the ovarian volume. Okay, yes, chalo, tell me what's the answer over here. Yes, we know that, sir, the Mullerian duct. Okay, when there is fusion, okay, there are two horns wide apart, that is our bicornuate, isn't it? We have also told you wide obtuse angle. So when there are two horns which are wide apart, that is because of fusion defect, failure of fusion of the Mullerian duct. Okay, if it partially fuses, there will be single cervix, two horns, that is bicornuate. Okay, and if it's a didelphus, for both the answer is the same. Okay, complete failure will give rise to didelphus. Okay, complete failure of fusion. Didelphus means complete duplication. What was there in the exam, anybody? It was bicornuate tha ya didelphus tha? Please tell me in the chat box. Okay, so failure of fusion is the answer to this MCQ. Okay, is it clear to all of you? And remember, this failure of resorption is again very important, will give rise to septate uterus. Is it clear to all of you? Yes. Moving on, moving on. Again, I am so happy, and this again you will have to tell me exactly kya wording tha, but some students told me, or all of them told me, sir, in one line only, all the components of active management third stage labor was asked. Okay, what all do we do? The purpose is to decrease the blood loss and decrease the PPH. Okay, bicornuate tha, very good. Okay, Shakir, thank you for telling me it was bicornuate surely. Okay, so chalo, didelphus nahi tha, bicornuate tha, and it was failure of fusion. Yes. Absolutely. Okay. Now here, yes, what do we do? All of we know that we give 10 units IM or IV within 1 minute of baby delivery, followed by control cord traction. That is the Brand Andrews maneuver. I think this name was there because 2-3 students told me, okay, sir, we could see Brand Andrews, that is it. Okay. We do not give misoprostol or methyl ergometrin, and we know that we don't do immediate cord clamping. Today, nowadays, we follow delayed cord clamping. Okay, delayed cord clamping. Okay, delayed cord clamping is to be done, and these are the three main things. And also, recently I had told you that the sustained uterine massage is not recommended as a part of AMTSL, specifically when IV uterotonic agent has been given. Yes or no? Thumbs up, clap if you got this correct. Okay, so here exactly administration of oxytocin and then followed by control cord traction or Brand Andrews maneuver. ये नाम दिया था. Was Brand Andrews name given to you in the question? Yes. Okay. Now, this is again so happy. Obviously logical. It's a simple question. All of you must have got it. Patient has come to you with infertility. Some 6 centimeter ovarian endometrioma is what? Chocolate cyst. Okay. Chocolate cyst is called endometrioma. And what do we do? दो ऑप्शंस था पूरे स्टेप्स 10 IU ask option था, मैंने किया, वेरी गुड, यस 10 IU वाला है परफेक्टली करेक्ट. 10 units ऑक्सीटोसिन देते हैं because AMTSL में we give 10 units only, okay, because this is for prevention. Please understand this, AMTSL is for prevention of PPH. When it is the management of PPH may we give 20 units and all that. Is it clear to all of you? So in management of PPH, we give 20 units. Very good, Shakir. Okay. Yes. So here we do not do oophorectomy. Pura ovary nikal doge, jail. Hysterectomy, oophorectomy options are there. It will go to jail. Okay. Only we don't aspirate. What do we do? Yes. Laparoscopically, we do the cystectomy. Only we preserve the ovary. Laparoscopic surgery is preferred nowadays. Laparoscopic cystectomy we do along with all the फल्ग्यूरेशन. नीट पीजी में ये भी आएगा, फल्ग्यूरेशन ऑफ द ऑल द, मैंने क्या बोला था, जला के राख कर दूंगा, रिमेंबर, जला के राख कर देंगे. सो फल्ग्यूरेशन ऑफ द endometriotic implants, they are called as endometriotic implants, all of them, all other will also be there. Yes, so we will go and do very good, yes. DP, Shakir, all of you. Okay, so fulguration of the endometric implants along with laparoscopic cystectomy. Yes or no? So the standard question. So overall, basically, बेटा आप लोगों का क्या था assessment के topics सब same थे. Topics all I had told. PCOS पढ़ के जाओ, endometrios पढ़ के जाओ, mullary anomalies. So topics सब same थे. Of course, थोड़े questions twisted and integrated थे. But previous year topics तो 100% everything was repeated. None of the new topics were there except one or two which I will tell you क्या था. Okay. Yes. Now again there is a slight confusion or controversy in this question. The diagnosis was I think already given to you. Okay. Okay. Previous two abortions are there. PIH or preeclampsia is there. So she has been made the diagnosis of antiphospholipid antibody syndrome. And here please understand what all we get. So we get recurrent pregnancy losses. So we call it as RPL. Okay. Recurrent. Okay, in Apla syndrome antiphospholipid antibody we can get, one is recurrent pregnancy losses. Second क्या होता है? Yes, severe IUGR, severe preeclampsia which this patient had. What can happen also? IUFD. Remember this also. The future के लिए. Okay, abruption. So all these are the complications. And what do we give when she is pregnant? So during pregnancy, we have to give both aspirin and LMWH. Is this understood to all of you? Yes. Warfarin we don't give. Warfarin, remember, warfarin I told you, we keep it only for metallic valve. Okay, heart disease in pregnancy is there. If it's a heart disease in pregnancy and when it is a metallic valve patient in the present body, then we give warfarin. So warfarin is not given for Apla syndrome. Is it given? Postpartum you can think of. So during pregnancy, you have to give low molecular weight heparin and aspirin. Yes or no? Hopefully यही options थे and hopefully all of you know. Yes, now here definitely controversy था because you'll have to tell me कि क्या था question exactly. Oxytocin था, नहीं था. Basically the labor is there and she has progressed to 6 centimeter. She's stuck over there for 3 hours. What do we know? So we have to assess ARM. I would have told ARM as the answer, but some told me, sir, ARM has already been done just now. So right now, if the fetal heart rate, of course, they should also mention about the fetal heart rate, which nobody has told me, because if it is fetal distress, obviously I will do cesarean section. There's no question of induction of labor. Image tha, okay, like a partogram image tha. So was it touching the action line? No. In 3 hours, it wouldn't touch the action line. So you just have to be alert, and we will alert and wait and watch would be the answer. Caesarean section mein the answer would be if it touches the action line, or if they tell you fetal distress or something about the pelvis has been told. If there is molding, caput, the baby head is very big, head is not coming down. I think fetal heart rate mention nahi kiya tha. That is wrong. So it is an incomplete question actually. Okay. Or we are getting an incomplete question from the students. Oxytocin. The best answer would have been, start, because contractions के बारे में भी नहीं mention किया था. So actually the answer would have been oxytocin plus ARM, but that was already done. If this was done, we would at least like to wait. We can wait for some time. Okay. Yeah, normal fetal heart rate, very good. So we can wait for some time, wait for at least an hour, and then also if it is not happening and if it's the same, okay, after waiting, if she's the same dilatation, then LSCS would be the answer. Is it clear to all of you? So I would give this in frequency, matlab as this as the option. I think wait and watch, probably because she's just been in 3 hours in labor, she's already progressed to 6 centimeter, and further she's not progressing. We have just done ARM right now. After ARM, if the liker is clear, okay, if ARM done and the liker is clear, then definitely we can further wait for some time. Okay, चलो आगे बढ़ते हैं. Yes, now this, my dear student, ये अन्याय था. This is the toughest MCQ ever in the history of the FMG examination. Even in NEET PG, this question has not been coming. And NEET PG students, this will surely come. I had told my students that twin to twin transfusion mein quintero staging. But they went one level higher. I said that quintero staging, remember name, and this question will be a virgin MCQ, will come in the future. But they asked one thing, that if hydrops is present in one twin, what is the stage of quintero? So the toughest MCQ, absolutely, it is a super special level MCQ. This student have been asked in the FMG examination. But agar aa gaya hai, I think and well, but I'm so happy. ये देखो कल का screenshot. Yesterday the exam was over. Yesterday the students are exactly stage 4. Same question from your notes. Fetal hydrops in one or both of the twin, stage 4. So Quintero staging, when it's a oligo poly sequence, we know that one baby is oligo, one is poly, that is stage 1. When the bladder of the donor is not visualized, matlab severe oligo. Color Doppler changes, stage 3, hydrop stage 4, and death, that is stage 5. Okay, so Quintero stage 4 is the answer, and that is when there is hydrops in one of the twin. Quintero is a ultrasonography, and we take help of ultrasonography and color Doppler to do the twin to twin transfusion. Yes or no? Tough MCQ. I am not sure how many of you got it correct, but that is stage 4. Stage 4, really tough MCQ. Okay, चलो आगे बढ़ते हैं. Okay, yes, I'm sure ये आपको देख के सब of what is this maneuver, anybody, and what is the purpose of this maneuver. So this is again many times we have shown to you. This is the Mac-Roberts maneuver, and in Mac-Roberts maneuver, when we give, basically when you hip hyperflexion, it flattens the sacral curve. Okay, flattens the sacral curve, and it is going to basically increase the pelvic outlet, so widens the pelvic outlet, so the shoulder will get delivered. Okay, so this is done for shoulder dystocia, and this is the Mac-Roberts maneuver. Yes, I'm sure all of you must have got it correct. Yes or no? Okay, so it flattens the lumbosacral angle or the and also anterior posterior, basically AP diameter of the pelvis increases. Okay, is this understood to all of you? Yes. Now again, if the missing IUCD, now I am for sure, I know that MRI option mein tha, obviously we don't do MRI, and directly you do not reinsert new IUCD, stupidity. Okay, and you also don't press the uterus and the cervix. So actually ultrasonography has to be done. Yes, very good, macro. Okay, actually ultrasonography has to be done, but ultrasonography was not mentioned. Yes or no? Ultrasonography is the next best step. Whenever it is missing threads, okay, missing threads are there, then we have to go and do ultrasonography. If ultrasonography facility is not available, I have told you we do X-ray, but only direct X-ray you do will not help. You do X-ray with uterine sound in situ. Why? Okay, because normal X-ray may you will not see whether your copper T is inside the uterus or outside the uterus. Okay, you will only see copper T ka shadow. So because uterine sound, so X-ray pelvis is done AP lateral view with uterine sound in situ. Yes or no? If this was in the option, then that becomes the answer. And many students told me, okay sir, that was not the X-ray ka tha, to IUCD hook. Yes, IUCD hook, or you can probe. Okay, now ये तीन अलग अलग options मुझे मिले हैं. You will have to tell me okay, what exactly was in the option. Okay, we don't press the uterus, and directly we don't proceed to hysteroscopy, laparoscopy. Once the diagnosis is done, then we can think of removing it with hysteroscopy, laparoscopy. We can wait and watch or not. Yes, very good defense. If it's superimposed, excellent. That is why we know. Okay, why do we do this uterine sound in C2? Sir, we do the X-ray with uterine sound in C2 because we know whether the copper T shadow and this is that. तो क्या था इसमें? IUCD hook था, gentle probing था. Yes, you can probe if at that time. Okay, next immediate step. Otherwise, it would have been X-ray pelvis or IUCD hook and probe. अभी you tell me exactly क्या option में था. Okay, MRI out है. IUCD insert another is out and we don't press the cervix or the X-ray option में नहीं था वेरी गुड सो देन अगर एक्सरे ऑप्शन में नहीं था very good then we know okay then the answer is probing the uterus with the probing the uterus with the you try to probe in or with a use of IUCD hook. Okay, if X-ray option, but X-ray is the second choice if USG is not there. Okay, moving on to the next. Yes, again tell me the age of the patient. 30 to 50 years made the best screening test for cervical cancer. I told you normal pap smear, normal pap smear or the liquid based cytology should be done every 3 years. Okay, and co-testing, clap if you have learned something. हमारे स्टूडेंट ने ताली बजाया होगा एग्जाम में. सर co-testing 5 years is the best option or that is preferred. What is co-testing? Sir, combination of LBC, liquid based cytology, and HPV testing and typing, that is co-testing. Yes or no? Visual inspection is not that great, and colposcopy is not the screening. Colposcopy is afterwards we take the biopsy from colposcopy. Is it clear? So co-testing every 5 years is the best screening. Is it clear? Best screening. Okay, low resource है तो normal pap. Yes, low resource है तो normal pap. Okay, yes. Moving on, tubal ligation के बाद leave. I'm sure your PSM teacher may have told you tubal ligation के बाद generally we give, if it there's no complication, 2 weeks leave. Okay, so slightly a new question, but this is more of a PSM thing that after tubal ligation how much leave a lady can be given. Okay, 2 weeks leave we can give her because it's a minor surgery. Any complications are there, then more leave. Okay, is it clear to all of you? Yes. Now please tell me something over here. Also the student tell me that sir some graph was shown to you, CTG was shown to you, or basically a NST was shown to you, and your AFI या Liker कुछ बताया था, and we had to do what was it exactly? Please tell me what was the exact question over here. Do we had to do the calculation of BPP or a BPP score was given? All of you know 10 by 10 is takatak, even 8 by 10 is okay, but 6 by 14 days or 2 weeks, very good. Okay, but ये क्या है? अगर BPP score is 6 by 10, if the BPP score is 6 by 10, then definitely even if okay we have to go for delivery. Okay, delivery या induction of labor या induction of labor या even LSCS में भी record the score is less. Okay, 6 by 10 है, 4 by 10 है, 2 by 10 है, तो ये था. So exactly many students are confusing this. Again we are not sure exactly what was the question, but something to do with BPP and biophysical profile scoring system the question had come. Somebody can comment what exactly was the question, then we can give you. Yes, now this was again a tough IBQ. This was something what was done, hysterectomy has been done, right? This was the question, mesh was fluid. Some student told me कि sir mesh का photograph दिया था, so you can see a mesh over here in the pelvic floor, and also there's a mesh. So the question was okay, what are the complaints of the patient? Anybody? Mesh surgery done and a hysterectomy was also done. They have given you this also. Was it mentioned कि hysterectomy done? Yes, hysterectomy done. So all of you know, okay, sir, vaginal hysterectomy, we do it for what? And the mesh is the pelvic floor repair. So the patient will have symptoms of something coming out per vagina or vaginal prolapse. Basically, the question was, okay, what was the indication of this? So again, a tough MCQ, but we know if they told you vaginal hysterectomy has been done, then this is a patient of prolapse. And prolapse is done, vaginal hysterectomy is done, so MESCA surgery. Is it clear to all of you? Cogwheel appearance. Again, I'm not sure whether this question was asked or not, but cogwheel, some student told me there, okay, what it is. Yes, that's when it is a hydrosalpinx, the cilia. So this is the option में coughing uterus prolapse था. Very good, excellent. Yes, Dhanger, excellent. Thank you for telling me. So clear cut हो गया. Yes, if there was prolapse and coughing, so definitely. And that actually the indication, right? Yes. Yes, so the prolapse. Okay, so this was a cogwheel appearance which we see in hydrosalpinx. Okay, hydrosalpinx may we see a cogwheel, because when the tubes are dilated, you can see incomplete complete septa. Nothing much to discuss in that. Okay, yes. Now here please tell me again, I'm getting confusion. मतलब ऑप्शन में कि aneuploidy testing था या some other sickle cell anemia या what it was. Okay, and patient was 16 weeks, definitely 16 weeks tha, but the question which student did not, so what many student directly they marked amniocentesis, wrong. But what is the question? The best non-invasive, please understand this. First of all, chorionic villus sampling we do between 11 to 13 weeks. Okay, amniocentesis is yes done after 14 weeks, basically in the second trimester. We generally do it between 16 to 18 weeks. We do amnio. Patient was 16 weeks, but please read the question. Non-invasive, NIPT, नाम में ही आंसर है. What does NIPT mean? Sir, non-invasive. What is the meaning of non-invasive? Because cordocentesis and all other are invasive. So NIPT is a blood test. Yes, non-invasive prenatal testing. This is a blood test. It is done on maternal serum. ओके, मैटरनल सीरम में हम करते हैं. ऑप्शन में नॉन, अच्छा, ऑप्शन में क्वेश्चन में इन्वेजिव नॉन इन्वेजिव नहीं था. ओके, इन्वेजिव नॉन इन्वेजिव अगर नहीं था, देन प्लीज अंडरस्टैंड दिस दैट एनआईपीटी इज 99% accurate but not 100% accurate. Okay, is it clear to all of you? So please, NIPT is done anytime after 10 weeks. Okay, after 10 weeks of pregnancy, anytime I can do NIPT. But if the question was confirmatory, then in the whole world the confirmatory test is only karyotyping, which all my students know, and then the answer would be amniocentesis. Is this crystal clear to all of you? Okay, invasive, non-invasive was not there. Very good. Then you know karyotyping. Then if they ask you the confirmatory test or 100% confirmatory if you want, then we have to go for amniocentesis. Is it clear to all of you? So then amniocentesis also becomes. So that you have to tell me. If it was the best non-invasive पूछा है, sir, NIPT, amnio is invasive, cordo we don't do, NIPT is non-invasive. Okay, so you have to tell me exactly क्या question था, क्या answer था. Okay. Okay, but here if the question was, okay, I put the question as best non-invasive testing, others are all invasive. Okay, so 16 weeks पे amnio करते हैं, 16 to 18 weeks पे. Okay, and then you have to decide the answer. So you tell me non-invasive था या invasive था. I repeat, non-invasive होगा NIPT, but NIPT is also the most accurate 99% screening test. Okay. क्या बोला था बेटा करंट एज के लिए? करंट एज के लिए क्या बोला था? ओके, यस. ओके, सो इफ द क्वेश्चन इज confirmatory, then you have to go for amniocentesis. Okay, yes, I'm so happy every time when I did the latest WHO sperm motility. Okay, 50% was old, 50% was old criteria, even 40 was old, 42%. Okay, total motility, total sperm motility more than at least 42%. Okay, 40 was the old criteria, 50 was still older criteria, और भी पीछे वाला. Okay, करंट एज में क्या करेंगे? सिग्मा रूल्स बेटा, लेकिन करंट एज में क्या करेंगे? इफ द क्वेश्चन वाज के यू वांट टू द मोस्ट इफेक्टिव स्क्रीनिंग टेस्ट, बिकॉज एनआईपीटी आफ्टर ऑल बिकम्स अ स्क्रीनिंग टेस्ट. Okay, screening test. Currently what would you do? So if they ask you the best thing or like the confirm it, so there's a difference between screening test. So screening test, NIPT is the most accurate, 99% accurate, and amnio is invasive, but confirmatory test पूछा है 100%, then amnio becomes the answer. There is no doubt about it. Okay, 12 weeks पूछा था, then 12 weeks पे CVS होगा. Okay, yes. 1654 क्या होगा? Yes. Okay, हाँ, लोएस्ट मतलब लीस्ट. यस, एटलीस्ट. यस, सो एटलीस्ट 42%. ओके, लीस्ट बराबर है, एटलीस्ट ही बोलते हैं WHO के जो भी वैल्यूज है, एटलीस्ट. सो इट इज ऑलवेज 42% और मोर इज कंसिडर्ड नॉर्मल. ओके, और मोर. सो 42% एटलीस्ट शुड बी द टोटल स्पर्म मोटिलिटी, एटलीस्ट. यस, यू आर करेक्ट. ओके, हाँ, लोएस्ट मतलब कि एटलीस्ट कितना स्पर्म काउंट होना चाहिए, कितना मोटिलिटी होना चाहिए. एंड रिमेंबर द न्यू गाइडलाइंस में ऑल्सो 16 million per ml. This is the count. Okay, count. So count should be anything more than or equal to 16 million. That is for the count. So keep this also in mind if the question comes in the future examination. Okay, very simple. I'm sure सबका ये correct हुआ होगा. 10 weeks pregnant lady for MTP. Only the patient consent has to be taken. You don't need the question of both husband, wife, or only husband or the chief medical officer. Only patient consent as long as she is adult. If she's a minor, then mother ka consent or the guardian ka consent, and then post-coital police informing, all that has to happen. But if it's a 10 weeks pregnant lady, an adult lady, healthy mind, then only the patient's consent has to be taken. Yes, I'm sure many of you when they got it, this is what, again last year PYQ ka thoda repeat, this is tandem and ovoid. What is this? This is the tandem. Okay, this what is introduced in the cervix through cervical cancer. For cervical cancer, this is called as tandem radiotherapy. Okay, and what is the purpose of this? What is the purpose of this? The question was asked that what is the advantage of doing this? Yes, because it will give local radiation. Okay, it will give local radiotherapy. We are going inside, so general overall, it's a radiology MCQ also. So basically they are going to protect the surrounding structures. Okay, it will cause least damage to the surrounding. Okay, so surrounding structures को least damage होगा. और basically that was the question. Is what are the options in this beta? Options इसमें क्या थे? Yes, what are the options in this? You have to tell me what is the option. But advantage of brachytherapy is that it is a local radiotherapy, and therefore there is least damage to the surrounding part, and this is tandem and ovoid radiotherapy. Please keep this in mind. Short question aa jayega. Okay, and yes, again very easy. Yeah, fertility. Okay, fertility preserve to nahi hoga beta, but yes, because you are ovaries are there, so ovaries may say yes, ovary is anyway not removed, so ovary में से patient can conceive after taking the eggs from the eggs, and then surrogation like the patient can conceive in the future, but mainly minimal damage to the surrounding organs. Yes, we know कि sir twins, they should of course also tell you which type of twins, whether it is DCDA or MCDA. इतने में ही, because MCMA we know, I have told you the rule कि sir MCMA, tell me sir, MCMA always LSCS, yes or no? So if it's MCMA, we always do LSCS, monochorionic monoamniotic. But here first baby is cephalic, so you will do a vaginal delivery. We will do a vaginal delivery. Second baby breech, no problem, because the route is decided by the position of the first baby. How will you deliver the second baby? Anybody? Obviously LSCS is not required. You don't do internal podalic version. Kachra dustbin. Internal podalic version is only reserved only cases if the second baby is transverse lie. There also we can do external version, and if not internal. And we don't need to do breech extraction. If in case internal podalic version is done, that is followed by breech extraction. Breech extraction means what? I will only remove the lower limb, then the buttocks, then the back, and then the head. Wherever it is breech delivery, I have told you assisted breech delivery is the best way. Is this clear to all of you? Assisted breech delivery matlab ke let the lower limb buttocks come out up to umbilicus of the baby, up to umbilicus. It is the maternal effort, and after umbilicus I will deliver the back, and then the shoulder, and the most difficult part, the after coming head of the breech. Is this understood to all of you? So this is, my dear student, you can see so many messages we are still getting in. Sir, I real OG, or you make the concept, I am all ops question correct. Again, some of the messages say your toughest questions also easy to remember, and we could grateful through you because of the OBGY. Many questions are from your notes and video lectures. Okay, so I wish all of you don't waste your time, and my dear student, look at this beautiful notes. You can easily completely color with all the images integrated just in 2 hours you can read the note, and this is your best chance. All those who are giving examination in the upcoming December and even the next year, please enroll in this. I'm sure OBGY will become your most favorite subject, most scoring subject is my guarantee. 30 to 35 MCQs come every year. This also, there were 30 plus questions. I think we have got around 28 to 30. Some few simple questions are there which many students have not been able to give me out because यही सब जगह से recall आ रहा है. So we have also tried to give you almost like 28 to 30 questions, but there were some, I think, 3-4 more questions. Overall, 30 to 35 questions are surely going to come, and you will get beautiful theory lectures, rapid revision MCQ, and my personalized timetable guidance. Get in touch with me on phone and WhatsApp on this number. Download the OGGuru app. Enroll soon. Thank you, Bada Vikram. Thank you. OG in the exam. Thank you very much. Okay, and leave lots of comments after the live stream is over. All my dear students, you can put in lots of comments how the exam was in the chat box, and do not forget to subscribe this YouTube channel. Please share this video with your friends and colleagues. The PPT will be available on the Telegram, and follow us on Insta also. I'm always available. Yes, it was a tough paper. Himmat rakhna hai and start doing your concepts. Okay, whether it's a NEET PG or FMG concept based exam, you need to have concepts absolutely clear. Only 3-4 months of preparation will not help. I request all those who are in third year, fourth year, fifth year FMG exam, start your preparation right away. 1 year's dedicated focus effort required. Don't take shortcuts, and 3-4 months would become difficult to crack the exam because lots of integrated long questions are coming. Yes, this was a recall session. Some options may be aage piche thoda sa, but from the best information I've got it. WhatsApp me if you have any other MCQs which you remember, or WhatsApp me if you remember any of the questions. Okay, bye bye, best of luck, thank you very much. Will be available soon for all of you again if you have any difficulties and doubts. Thank you very much, and share this video with all your friends and colleagues.